Good morning. I feel the same way how everybody feels for a Sunday, but then let's talk genes in uveitis. So practical considerations. I'm not trying to go into too much of theoretical stuff. It is not that we are all very aware of a lot of genetics in uveitis. That's the kind of upcoming things. So let's see. Sometimes you want to tell that there are no financiers itself, so where do you disclose any financiers? So uveitis has multiple etiologies causing multiple entities. You can have infective, non-infective, and there are some trauma and other things also. So we have many different groups of genetic associations with uveitis, like HLA association, the inherited ones, the inflammatory genes and other ones. So genes probably can be causative. They can probably have an association, whether it is the causative or not, we don't know. Sometimes it facilitates the process of the disease. So few of it we already know, few we are getting to know. So what we already know for decades is that HLA is the one that has been very well associated with uveitis. So HLA-B27 is the most popular one and is strongly linked to the development of anti-uveitis. We know that it can be associated with Reiter's, ankylosing spondylitis, inflammatory bowel disease, psoriatic. So all these HLA histocompatibility genes which are associated with the inflammatory systemic diseases can cause uveitis. So how is the frequency? About 50 to 90% of the patients with HLA-B27 positivity may develop uveitis. So the other strong association is about HLA-A29 with birdshot. Birdshot we don't have, birdshot is not that common in India. But then there are other things like sarcoid which we actually see, where HLA-DR and other autoimmune diseases can be formed. The other scary one, other than HLA-B27, I'm always worried about is when you are waiting for a report to be positive, you are very happy sometimes that you made a great diagnosis, but then you don't want it to be positive because it's a very scary disease. Like severely vision-threatening one, HLA-B51, the most scary one. So B51 positivity is not mandatory for diagnosis of Behçet's. So if you have a history of aphthous and genital ulcers, if you have some systemic thrombophlebitis, then you're probably dealing with a case of Behçet's. But then it's an important factor in determining the clinical phenotype. So there is something called epigenic interaction between B51 and the IRAP1. That explains the pathogenesis. So if you have suggestive clinical features, that is not mandatory, but if it is positive, then it's with clinical features, it is suggestive. So if there are suggestive clinical features, if you have a hypopyon panuveitis, you have ferning appearance, you have occlusive vasculitis, and you have systemic features with B51 positive, then you are definitely dealing with a case of Behçet's. So why you have to be so particular about Behçet's? Because Behçet's is probably primary indication of biological therapy. So if at all you are starting off biologicals initially in any disease in uveitis, probably Behçet's is one and GRA is another one. So you may sometimes have HLA-B51 positivity. I'm actually currently dealing with a patient of granulomatous anterior uveitis with CMV positive, which is B51 positive incidentally. They had tested it in US. So it is not necessary that sometimes you need to test based on the clinical features. So when you look at all this, we keep worrying about when to test for these inherited genes. If the gene is positive, is it specific for that disease? How are the chances of this disease occurrence? If the gene is positive but there is no disease, do we get a situation like that? Yes, we will get to it. There are some associated factors and then we'll look into it. So when to test for inherited genes? So obviously, if there is more than one family member affected by similar signs and symptoms, then you will definitely look for probably if something is happening in the family together. For example, this was one lady who had come with on and off steroid treatment, being treated as JRA, one-eyed, presented to us in 2017, and for the past 17-18 years she's on treatment with us, tried various combinations of medications, and finally currently she's stable on methotrexate and mycophenolate. She had a granulomatous panuveitis. She had this joint deformities and posterior segment lesions. Her son, a 3-year-old, was brought to us in 2014 with recurrent granulomatous uveitis. We again thought probably TB, intermediate uveitis, GRA. Also had some toda dry skin, which was something suggestive. So, but now currently he is stable on tofa and methotrexate. Similarly, is the story with her another daughter who was ANA positive, which is misleading actually, and toxo IgG was raised. It is not relevant. So if you don't have a clinical lesion, if you have toxo IgG raised or ANA, then you take it with a pinch of salt. So again followed up very well, stable on tofa and methotrexate. So this is a combination. You have a family of mother, son and daughter, all of them having similar granulomatous uveitis. So we tested for NOD2 mutation. When in 2013-14 we were not that aware of it. Now obviously we are aware, and we expect everyone to be aware of the fact that if you have a granulomatous uveitis, especially in a child, it is not GRA, look for BLO. So NOT2 mutation, if it is positive, there is something called familial BLO. So boggy arthritis, skin lesions, and uveitis, it is a triad. Remember, it has to be granulomatous, and it can be misdiagnosed as TB sarcoid, and don't think it is JRA. So we reported the first familial BLO syndrome, and then we were wondering, if we found 3 of them in the family, are there many more in the family? Yes, there are many more in the family. Many were actually seen by my colleagues in the other room, and they were walking around, then we realized that they look similar, and probably we realized that they belong to the same family. So about 17, 18 of the patients in the same family all have these clinical features, and we tested for NOT2 mutation. So among those family members who were all NOT2 mutation, all of them had clinical features, and all those who were negative with NOT2 did not have signs and symptoms. So it means that it is very specific gene. This is a family tree of them, and even the 4th generation, 1, 2, 3, and 4th generation, the 4-year-old kid is also affected now. So she is being treated with us now. So BLO is one thing. Again, I'm like blah-blahing about BLO. So BLO is very important actually. So it's not just about BLO among inherited ones. This is another thing. A young adult, she's about 18, 19 years old, under younger brother. She had history of hair loss, early graying, and hearing loss. Had recurrent anterior uveitis. Her brother had like typical like GRA kind of presentation with BSK, chronic anterior uveitis. He also had hearing loss, but he also had history of pancreatitis. But he actually has dense hair, like no hair loss and graying. So this hearing loss and uveitis, we were thinking of one disease. Obviously, we all think of Cogan's. So you're wondering, but there are some disparities in this. Is there a genetic association with Cogan's? So again, they were treated with the combination of methotrexate, mycophenolate. This is how we go. We used to go initially, but now probably again, to repeat, biologicals is probably primary indication in patients with JRA. So undergo now stable on tofan methotrexate. So we tested for genes, and then we found that there is a biallelic mutation in TKT in patients with Cogan syndrome. So this we have actually reported. Mutations in TKT gene was seen in the homozygous state in patients with in the boy and the affected sister. But the parents were heterozygous. They have a third sibling who was a wild type homozygous variant, which was not associated with this. So it's important that it's so good that genome testing, that you know which gene and which kind of variant is there and which is related to the disease. Again, another one. A 5-year-old came to us about in 2015. She was stable for about 5 to 7 years. In December 2020, she had active inflammation and started the process of deteriorating. Vision started dropping. So luckily these parents were ready for adalimumab, and we started on adalimumab and methotrexate. But then 2 years back, they came with some kind of lesion like this. We were wondering whether it is flictin. So caution, in India especially, biologicals are very good, but then you always think of ruling out tuberculosis. So we thought whether it's flictin or not. We started on topicals, but then it watched and it got okay. And in about a year's time, everything was fine. When we did cataract surgery, she was doing well. So we thought like it's fine. We have gotten away with it. But then as always, it didn't end like this. In Jan 2025, she came back with granulomatous anterior uveitis. So we went through the whole process of blood testing, turned out to be negative. So I kept telling that granulomatous and uveitis, then it is BLO, but it may not be BLO also sometimes. TB it could be, then turned out to be negative. But then we had sent for whole genome sequencing, and then turned out to be RP1 gene positive. We are wondering like, how come RP1 gene positive in this? Did multiple tests, everything were normal. Then we were worried that are we dealing with combined diseases. But then the fact is that, like in any other lab test, sometimes better not to test for genomes which we don't suspect. If you are suspecting, they say like when you test for the lab test based on which you will treat. If you are not going to treat based on that, then you don't test for that. So if you are looking for NOT2, test for NOT2. Don't do the whole genome testing. Ask for specific ones whenever possible. So this is false positive. So you can have false positive also in gene testing, and also see how much of association is there with the genes with that variant. That is most important. Just because it is RP1, it doesn't mean that patient has RP. So you know all that, like not all HLA-B27 have uveitis, and we saw that all NOT2 mutations have disease. But why is that? There is something called monogenic and polygenic uveitis. The monogenic uveitis have mutations in a single gene, so the association is very strong, something like BLO or CARD15. In a polygenic one, the multiple genes contribute to susceptibility, like B27, B51. So in this situation, it may or may not be associated with disease, but in monogenic situations, it can be associated with the disease. The third group, the inflammatory ones, these are the current therapeutics are directed towards these, like the IL-23R, TNF-alpha, interleukin. So this, we have a talk on biologicals, they'll be dealing with it in much more in detail. But then the TNF-alpha variations increases the susceptibility to uveitis in patients with inflammatory disease. Okay, I was talking about family, then one more family, last minute. A 9-year-old female with TOFA and methotrexate stable had a recurrent intermediate uveitis, so started on TOFA. A brother also had similar presentation. But then this kid had a granulomatous anti-uveitis, so again we went through the process, not too negative. But then AC-type MTB was positive. So this gives us another lesson that if you have uveitis in the same family, needn't mean genetic always. Beware of common environmental exposure from the common gene pool. You need to understand that you can have a common gene pool, but in India you need to understand that you can have a common environmental exposure also. Her uncle or grandma who was living with them had a history of tuberculosis. So environmental factors and your genetically predisposed individuals have a interplay. Similar to what we saw in COVID, not all COVID vaccinated people were getting some disease. Some of them are having. We have this COVID vaccine associated VKH and so many things happening. This is one 60 plus old person getting VKH. So they've already studied and found that immune regulatory gene polymorphisms are in play. So we are talking about autoimmune. Infective also, HLA association is known, but not that strongly. Innate immunity genes like toll-like receptors are known to have a thing. That is what is being studied now. But then, like my favorite always, obviously there is a strong association between immune recovery uveitis and HLA-B881 in patients with HIV. So patients with HLA-B27, B57, also associated with sweet syndrome, can have associated increased risk of infection in HIV patients. So it's important to be aware. We had a survey where all of us are part of it. We honestly rated ourselves and found that we were all poor in diagnosing monogenic uveitis specialists and rheumatologists, and the commonest monogenic uveitis which we were all ordering is not 2. So it can be probably genetic, or sometimes like people call it nepotic. So uveitis seems to be all about genes. So it's a crucial role. It plays identifying high risk in autoimmune associated uveitis. You can, in India, you need to rule out tuberculosis, otherwise not 2 is the happening thing. So early diagnosis and treatment is inherited things. So personalized medicine like adalimumab is very helpful. But more important one is like if somebody already has a monogene, like what you are going to do? You'll help. There is something called CRISPR gene editing, so which they target the gene itself to modify the gene so that the next generation doesn't get the diseases. Thank you. As being USA secretary, this is my role in inviting you all for the UCCon conference. You'll have great uveitic talks on 3rd, 4th, 5th and in Jammu. And Shankar Netralia has a retina meet. Please come. Thank you.
Thank you, Dr. Sudharshan, for the excellent talk with good case examples on genetics and uveitis. Any questions to Dr. Sudharshan?
Yeah.
Yeah, Sudharshan, a really nice presentation.
Thanks.
Only thing when you show us the first pedigree, okay, it was a autosomal dominant. And next case, you did not show a pedigree, and consanguineous marriage was there, autosomal recessive. Now, if in uveitis practice, if we can do a pedigree, that's a very important, which I believe none of uveitis experts are doing, okay? Because if you can screen them autosomal dominant, autosomal recessive being worse in the condition and and runs in a very aggressive way, that will be very good. Now, thing is that for HLA-B51, okay, I'm a bit skeptical on one thing, okay. For Behçet's, it's not only HLA-B51, it's also B52.
Yeah.
Why it is important? Because Behçet's has a systemic vasculitis component also, okay, which can involve a neurological component also. So sometimes HLA-B51 may be negative, but HLA-B52 may be positive. So I believe the 2 tests are also important for Behçet disease.
Yeah, I totally agree. Like because whenever we ask for HLA-B5, they seem to be doing a spectrum of it. So that's how we start getting this B5 and all. About the vasculitic component, that's what I was trying to mention. That if you have a thrombophlebitis, like that's one indication that the patient is towards Behçet's. If you have a systemic thrombophlebitis because of occlusive vasculitis or systemic vasculitis, then that's an indication for thing. And pedigree we've not been doing. This is because luckily many patients of the same family had this, so we started doing this. Otherwise, we don't seem to do. But which is a very good point that we'll have to be doing it. one point related to the pedigree or the aggressiveness which I want to add is that it is not always familial in the whole family children. There can be sporadic mutation in a single person also. So maybe other patients in the family may not have anything, only one kid may have, that's a sporadic block.
Thank you, Dr.